Good afternoon, everybody. Good afternoon, Perth. They're alive. Welcome to Grand Rounds. My name is Tom Ford. I'm the chair of Grand Rounds. Well done for negotiating the return to the Gannick Lecture Theatre rather than being in the Wolfson. So I have, as usual, a few small parish notices. I suspect there'll be a few more people who will dribble in as it goes on. Let's start off. Researchers from the University of Dundee are seeking hundreds of families to help them trial a new smoke alarm, and particularly the specific sound aimed specifically at waking up children. The number of lives are lost every year as a result of fires because children do not wake up with the deafening sound of commonly used smoke alarms. Professor Nick Dade of University of Dundee Centre for Anatomy and Human Identification, and her research student Dave Cross, a fire investigator and watch commander with the Derbyshire Fire and Rescue Service, have developed a new fire alarm which will hopefully wake up the children. Professor Rami Abood, Associate Dean for Learning and Teaching and Head of Postgraduate Division, was a keynote speaker at the 38th Annual Conference of the Indian Association of Sports Medicine, handily acronym of IASMACON, in 2007 in Goa last month. Professor Abood was on hand to share his vast knowledge of biomechanics in sport to an audience of physiotherapists, coaches, sports medicine students and orthopaedic surgeons. Dr. Graham Arnold and Sadiq Nasir also attended to present a mini workshop on setting up a gate laboratory, albeit virtually, and demonstrate the process of data collection through to analyse results. This was a tremendous success and generated lots of interest in postgraduate study over in Tort here in Dundee. An upcoming masterclass from a former School of Medicine student, Chris McCann, smiling away there, who founded Snap 40 on the wards based on his clinical experiences. Snap 40 is designed to detect signs of deteriorating health earlier by automatically using a wearable armband, and Snap 40 continuously monitors for more vital signs than any other device on the market, analyses in real time, and then directs doctors and nurses to those at highest risks. It's a newsometer, basically. We wear it on the wrist and it measures your news and then beeps and sends it wirelessly. He was a medical student here a couple of years ago. Here are the staff development opportunities coming up this month, some with lunch and some without. The ones with the stars are the free lunch, for those of you who are hungry. I remind you that this has been commended by NES as being an exemplar of the best quality teaching for postgraduates and staff across Scotland. So if you are interested in teaching, you need to revalidate, then please do go along. Next week at Grand Rounds, for the third time of asking, the haematologists are going to come and talk about their massive hemorrhage policy. Katie Hans will come along. She's an acting consultant in haematology, a talk postponed from last season. So it will be of great clinical importance to us all, so please do come along. And on we go to the presentation at hand. I was cycling with Nick just a couple of months before Christmas, and I said I've not had the ophthalmologist along to do Grand Rounds for a while, and he said, oh, yeah, so, which I took to mean, yes, I will come and do a presentation at Grand Rounds. So thanks for coming. But he's not alone, he's brought another bunch of folk with him, and I think we're starting off with Margaret, who's going to come and talk about, I don't know what she's talking about, because I'm about to find out. Paediatric Cancer Service is what she's going to talk about. This is Dr. Margaret Peebles, and off we go. As usual, I'll be on hand at the end for any questions, so save them up. And if you do have questions for Margaret, she has to leave straight after her bit, so we'll perhaps get some...
So Kirsten's answering the questions on my behalf.
Oh, well, there you go. It's all been organised. Okay, thanks very much.
Thank you. We're doing a joint presentation. Nick's had some interesting cases this year, but I thought I'd just talk about cancer services briefly beforehand, because they are slightly different for children compared to adults. So cancer in children is rare. So these are the figures for under 16s. There are 150 new cases of children with cancer per year in Scotland. So it's tiny practice compared to adult medicine. If you add in up to 25, that becomes 300 cases a year. The commonest tumour we see is leukemia. Brain tumours are the second commonest, and some of the eye tumours come into that classification, such as your optic tract gliomas. Commonest solid tumour is a neuroblastoma, which is a nerve cell tumour, usually arising from an adrenal gland and seen in children, not in adults. And just to give you an idea of how common eye cancer is in children, the eye tumour that everybody or most people have heard of is retinoblastoma, and we get one new patient with retinoblastoma per year in Scotland, on average. The way cancer services run in children are very different to adults. In 1977, there was a group of paediatric haematologists and oncologists realised that the only way to improve outcomes for children was to work together and to have multi-centre trials. And that's where paediatric cancer services started. In Scotland, they developed in the 80s a Scottish paediatric haematology and oncology group, which met 2 or 3 times a year, mainly for education and for sharing difficult cases. It has always been multidisciplinary, so the nurses have been invited from the beginning. AHP staff, pharmacists have been involved. So we pride ourselves on having multi-centre, multidisciplinary team working before anyone else, really. In 2006, this group was finding it difficult to get funding issues. There was changes in rules about drug sponsorship. Tumour boards were beginning to be put forward as best practice. So therefore they wanted to develop multidisciplinary team meetings around the patient. In paediatrics, we wanted to use telemedicine. The Scottish Government in 2007 produced a document about the way forward for children's services, and that did state that there should be more involvement from district generals, there should be shared care centres, and there should be a tertiary service overarching everything else. So from that came CAT-SCAN, the Children and Teenagers in Scotland Cancer Network. We like names for things, not long words. This involved all the primary treatment centres, so all the primary treatment centres are actually 3, Aberdeen, Edinburgh, Glasgow, and the shared care centres are Inverness, Dundee and Dumfries. This group started developing work streams around having national protocols for supportive care, having clinical governance overarching cancer care, starting to involve pharmacists and allied health professionals in their own work stream. It has become apparent over time that good diet, input from physios and OTs keep children healthier during and after their treatment. The next thing that came along from the government was the National Delivery Plan for Specialist Paediatric Services in 2010, and as part of that it was decided there would be a managed service network, and this was to be formed by April 2011, so lots of time to organise it. The government actually tried to move quickly occasionally. What is a managed service network? Basically, there is a board that is answerable directly to the government, and under the board comes the operational delivery group, which most areas have representation on. So it was launched in 2002 with the first cancer plan. It's a single service for the whole of Scotland. The government decided it would cover the age group 0 to 25 years, so that's about 300 patients per year. That's quite difficult, and I think to begin with, the cancer plan definitely concentrated on the 0 to 16s, and that was because it was being led by paediatricians who were used to working with 0 to 16-year-olds or 0 to 14-year-olds. This network has developed joint protocols for supportive care, so we have a national protocol for the care of febrile neutropenia. We have national guidance on when to transfuse blood and platelets and how much to give. And we are currently developing a joint protocol for, I've forgotten what it's called, Ian, for hemolysis. Tumour lysis is the latest national protocol we should have. So every child should get the same standard of care for those supportive elements of their care. We currently have national MDTs for solid tumour, leukemia, palliative care, and teenage and young adults. We have local MDTs for neuro-oncology, also for solid tumours. So for us, a local MDT covers Aberdeen, Tayside, or Grampian, Tayside, and Lothian is who we join. And we do them by telelink, so we're not shooting off around the country all the time. We are staying in Dundee and just switching the telly on, or the computer. So the cancer plan wanted us to promote national MDT working so that every new patient would effectively get a second opinion from the other centres who would present to one centre. They would look at the pathology they had, the scans they had, and make a diagnosis and a proposed treatment plan, and that would be reviewed by the rest of the country. We've to continue developing a governance framework to have agreed referral guidelines. We want to promote early detection, and we have done some work with GPs in Tayside around that. We have an e-health strategy. If anybody can tell us how we get chemo care with a licence for multiple health boards so that we can actually electrify or make our prescribing electronic for chemotherapy, we'd be very grateful, because we've been trying for over 10 years and not succeeded. We are involving patients, carers and third sectors, so if you go along to the operational delivery group, there is a parent representative there. And we want to ensure equity of access and improve outcomes for the care of children throughout Scotland. It is actually, particularly leukemia care, is one of the success stories over the last 40 years. For ALL, we have gone from 0 survival in 1965 to 85 to 95% long-term survival in 2016. So I think that is a great success story, even over one person's lifetime. So our managed service network has now updated the cancer plan and is concentrating more on the up to 25-year-olds. But it does say every child and young person in Scotland should have the same access to the same treatment and the same standard of treatment no matter where they live. They should have access to clinical trials, which has been difficult and is becoming harder with legislation that's come in over recent years. They should be cared for in an age-appropriate environment, and there should be improved outcomes for all ages. What happens here? Well, for the 0 to 16s, and sometimes we will take up to 18-year-olds, we are a shared care centre, so we do all the chemo for ALL after induction, and we do some of the chemotherapy for solid tumours. Our primary treatment centre that we do most of our shared care with is Edinburgh, although we will do shared care with other centres such as Aberdeen and Glasgow, or for your retinoblastoma, we do shared care with Birmingham. We have 3 consultants working in the team, which is 1.3 whole-time equivalent of an oncologist or haematology oncologist. We have 2 paediatric oncology outreach nurses who share a 1.2 whole-time equivalent post. We have 1 half-time oncology nurse. We have a clinic sergeant social worker. We have pharmacists. We have access to dietetics, physios, OT, psychologists, dental hygienists, and there's someone else I think I've missed off the list. Speech and language therapist as well. And we have access to local charities. And I think that's how to contact us. But one of the reasons we want contacted, if you think you have a child with a tumour, is that we treat them slightly differently in paediatrics. So often we do a lot of scanning before we do the biopsy, so that you don't get reactive lymph nodes near your operation site, because that can upstage the tumour and inflict more treatment on the children and therefore potentially more long-term side effects. And we want them to reach adulthood, and most of the specialists in this room, in a healthy condition with no long-term effects. There's also, if we're sending children out of area to get the best treatment, what happens to the parents? We're well aware we live in an area where there's a lot of deprived children, and you can actually push families further below or below the poverty line by sending them to Edinburgh. So the importance of being in touch with us is we have access to local charities who will financially support these families. We will also make sure the Click Sergeant social worker is involved and that any benefits they're entitled to get sorted out sooner rather than later, because we don't want this to be at the cost of the health of other members of the family because there's no food to feed them or don't get such a healthy diet over time. And that was really all I had to say about paediatric cancer services. One quick
we'll subject you
question.
to some questions. Does anyone have any questions for Margaret whilst Nick comes and sorts out his presentation? Anyone got any questions? If not, it looks like you escaped.
Silence.
Okay. I'll sort this out.
Thank you.
Righty-ho.
I put stick in.
Have you put your stick in?
It's in, yeah, it's on this Patriot.
Super. Bear with us whilst I just sort this out.
Patriot. Yeah. Paediatric Cancer talk. Very kind.
This one?
That's the one, yeah.
We'll just run it from there then. That's fine.
Lovely, love. Yes, lovely. Grand.
Okay, there we go.
That's lovely. Thank you very much. Thank you for inviting me here. I apologise for not coming to the previous meetings, but unfortunately I was saddled with a Thursday operating list ever since I've been here, so it's always difficult to escape. But I would like to point out that Tom was indeed correct that he did ask me to speak at this meeting whilst on a bike ride. But I would like to point out, in regard to my answer, he was actually cycling at a pace which was much, much faster than I could possibly manage. So I was slightly out of breath when I did say to him, I never talk about work when I'm enjoying myself. But I did say, email me and I'll do my best to get a talk. So thank you for asking me, Tom. He's a much better cyclist than I am. I thought, with this talk, I mean, eyes is a very subspecialist subject, but I wanted to try and present something that will probably have some little tips and bits of advice and general doctoring, as well as some specific eye problems. Cancer in children presenting to the eye clinic is not particularly common. I think, as Margaret said, we see one retinoblastoma a year. And often it will masquerade as other problems. Sometimes it doesn't look like cancer when it comes to the eye clinic, and I'll show you some examples of that. I think the first thing to say as well is that children don't complain of anything. They probably will be hardly able to see anything, and if you ask them if they had any problem with their eyesight, they'd probably say no. So they don't complain, and children don't always want the eye doctor to look in their eyes, so that can be quite difficult. I think sometimes when you have a suspicion there might be a cancer, you've got parents there who may have taken a child to a clinic with something fairly trivial, like they noticed a funny colour of the eye on a red reflex on a camera shot, and suddenly the whole consultation changes, and this might be actually the very worst moment of their life, the moment you say those words. And so, it can be quite a difficult thing. Sometimes we have to say things that we're not sure about, and that might be very bad news for the patient. Children aren't easy to investigate. We send off blood tests on adults and MRI scans, but every investigation on a child has connotations. Paediatricians might be finding it difficult to take blood. An MRI will require a general anaesthetic in a lot of children, and that's no mean undertaking. I would say one thing, that in quite a lot of kids that I'll show you examples of, the ophthalmology science have helped to clinch the diagnosis. So some of these kids have had fairly vague symptoms, nobody quite knows what's wrong with them, and there's something in the eye that suddenly hones the diagnosis down. I'd like to say the last thing is that the help of colleagues is very invaluable, I think, in these situations. One's aware of one's limitations in an eye clinic and how we deal with patients. And I've had great help from the paediatricians, oncologists, neurologists, ENT surgeons, anaesthetists. And one case springs to mind not long ago. This boy presented when I'd been away on holiday, and he was waiting for me when I got back. He'd had what was billed as a nasolacrimal sac abscess. I went to the radiologist, said, "He sure there's an abscess there?" Yes, so we put a knife in it, and it was solid. And this was a Friday evening, and so the diagnosis wasn't as we suspected. I had expressed some slight concerns to the parents, so we were slightly prepared for it. But I rang Buddi Guteratnae, unfortunately he was available, came straight down, and we had a conversation to the parents, which, whilst it wasn't the best conversation they had, his professionalism and his ability to deal with these situations, as he had done countless times before, put the parents at great ease. They knew what was involved, what was going to happen, and I think it was a huge help. So, I find, the best thing I can do really sometimes is ask for help from colleagues, and that can sometimes help you through difficult situations, so thank you. So I'm going to say a little bit in this talk about what is paediatric ophthalmology, what do I do that's slightly different to my colleagues. I'm going to talk a little about tumours in the eye, tumours in the brain, and tumours around the eye, and they're probably the sort of types of things I've seen. And I'll try and put across one or two things that I've learned. So in the eye clinic, I'd say about 80% of my work is kids with reduced vision, glasses, squints, lazy eyes. We occasionally see kids with nystagmus, and that needs something that's of some concern in itself. We see lots of kids with orbital cellulitis presenting, particularly in the winter when they've got coughs and colds. A bit of conjunctivitis, kids with abnormal red reflexes. So that's what sort of my everyday type of work. How do kids with cancer present to the eye clinic? Well, they present with all those same things. I can show you an example of all these conditions that are presented to us with cancers. And these things happen very rarely in a situation where we're seeing fairly common problems. I think assessing paediatric eye problems isn't always easy. I always tell medical students that, probably paediatrics in general, but certainly paediatric ophthalmology, examination comes before history. If you start taking history off the parents, the child gets really bored, and then just adults having an adult conversation. So they're very egocentric children. So I often look at the kids as they come into the clinic. Are they seeing properly? Can they navigate around the room? Have they got an obvious squint? Have they got an obvious wobble to their eye? Are they generally well and bouncy? And because that might be the only chance you get to have a look at that child, and then gradually hone in on the eyes, and if you're lucky, you can get a view of the fundus. So everyone, all my colleagues, Dr. Glynn over there, do ophthalmology because it's a very visual specialty. We can see a patient in the clinic here. The patient has diabetes, and we can get them on a slit lamp with our lenses and look, and then we can see a pre-retinal hemorrhage there, and we can see lots of blot hemorrhages. And then if you look a little bit to your right, so and upwards there, we can see the new vessels. That's really good, and that's why we do ophthalmology, because we love to see those sort of things and diagnose them. This is a one-year-old child who had poor vision in his left eye, came to the clinic. We had a look at his fundi, and we had a look at the other eye, and then, and that was all we got, really. So that's often what happens. You get a quick look, and you're expected to make a diagnosis. But for the sharp-eyed amongst you, you will see here that this left optic nerve is slightly smaller than the right. He's got optic nerve hypoplasia, which is why his vision's poor. He hasn't got cancer. But sometimes we're dealing with quite subtle things that are difficult to see. So I'll just talk a little bit about intraocular tumours. This is probably a bit ophthalmological specific, so I'm probably not going to spend too much time on this, but really any child with a poor red reflex should be seen fairly urgently. And most kids with intraocular tumours will present with an abnormal red reflex. And most patients with an abnormal reflex will have nothing wrong with them. Most patients come, they've had a photograph. Everyone takes millions of digital photographs nowadays. And somebody, usually a relative, a doctor, has said, your child's got a funny reflex there, needs to be checked. And the parents get very concerned. And it's just that, as in this child here, the photograph hasn't been taken on axis. This child has a slight squint, which is why it's not axial. And so it's given us an unusual red reflex. But what you don't want to miss, really, is that one case every now and again that's a retinoblastoma. And some of these tumours, it's a dominant condition with variable penetrance, so it doesn't always, families aren't always aware that, Grandad had his eye removed years ago because of tumour. They usually say, well, he banged his eye and had it removed. So some of those kids, the diagnosis isn't always made, and quite a lot of these tumours will arise because we're screening the families. We know there's a risk in that family. But some of them will arise sporadically. I'm not going to talk too much about retinoblastoma. This is a very typical case. Child was referred because there was a slightly unusual appearance to the eye. And what you will see here is that there's a whitish mass here behind the lens. So this behind the lens, and it's calcified. And these other areas, areas where the retina is folded, you might see some little blood vessels there. It's probably a bit poor slide. So this child has got an intraocular mass with a retinal detachment, and that's most likely retinoblastoma. But there are other conditions that can cause that. But one of the things that's often useful to do, and people often forget to do, they hone on the organ that's got the pathology, and it's always useful to look at the other bits of the body. And in our case, we all got two eyes, or most of us did. And it's useful to look in the other eye, and this child has a small tumour in the peripheral retina, and that clinches the diagnosis. This child's got multifocal retinoblastoma. They've got a mutation in all their stem cells, in all their germline cells, so they're at risk of multiple tumours. So it's always useful to look in the other eye. These children, as Margaret mentioned, go to national units, which for retinoblastoma are Birmingham and London, and there's regimes where you can treat with chemotherapy. This eye was enucleated, unfortunately, but the other eye was treated with local laser treatment and chemotherapy. This is another baby who presented at 5 months last year. And the red reflex was abnormal. You can see there's a white. This is just an artifact from the lens, but there's a white reflex here behind the pupil, and there's actually, it's not showing it well here, but there's hemorrhage here around the edge of it. The query was whether this child might have a retinoblastoma and should we remove the eye. But again, I think learning point again, examine the other eye. This child has got some bleeding in the other eye, and actually it's very subtle here, but his retina was not completely vascularized. He had a very rare genetic disease called Norris disease. But the important thing, it's not retinoblastoma, so look at the other eye. It can often give you a clue. Just move on to brain tumours. We really see about 3 or 4 different ways brain tumours present to us. Probably one of the most common is headaches and papilledema, and some of those kids will go to the paediatricians with headaches, and they might ask us to have a look, but quite a lot come to us with papilledema from the optician. So the patient goes to the optician with headaches and they have papilledema. And this child has very obvious papilledema, had a posterior fossa tumour, very dilated vessels, some hemorrhages. We do get lots and lots of kids referred to us with slightly query swollen disc, pseudopapilledema. And one of the most important things is really the history. Often the optician will look in the eyes and be a bit concerned and say, have you ever had a headache? And of course the child says, yeah, I had a headache about 4 months ago, and then immediately brain tumour rings bells. But most of these patients usually just have pseudopapilledema and don't need any further investigation. So I think the history is very important, particularly with regards to headache. This is a child who had visual failure. By that we mean loss of visual acuity and visual field loss. She was a 5-year-old girl who failed a school eye test, just went along routinely. She had moderately reduced vision, 6/12, and she was thought at that time to have functional visual loss. There's no further treatment or investigation done. But one of the things that, I'm not a psychologist or a child psychiatrist, but I know for a fact that children don't present at the age of 5 with non-organic or psychological problems. They're much more common. We see them fairly commonly in kids of 10 or 12 years of age. 5-year-olds, we don't see them at all. And so, any child of 5 years old with some reduced vision that's not correctable with glasses should be taken seriously. The child presented a year later. The visual acuity had dropped. The child had headaches and had polydipsia and polyuria, had symptoms of diabetes insipidus. The visual fields are very difficult to do on kids, but this child had extensive temporal field loss in the other eye, and you can see this other eye has extensive visual field loss. She's got bilateral optic atrophy, and so she's probably got a visual pathway tumour. And indeed, she had a hypothalamic glioma, which was impinging on the visual pathways and causing significant visual loss. So these kids can just creep up with reduced vision. One of the important things to do, I think, in kids with a visual pathway glioma is to think about neurofibromatosis and look at the family members. And in this particular child, there's no other family history, but actually it's important to examine other family members. And actually, Mum came up, she'd had a below-knee amputation for an unusual cyst on her leg in childhood. She kept getting recurrent fractures, had some sort of bone cyst. But when we looked at her eye, she got lots of Lish nodules on the iris, and this is very typical of neurofibromatosis. We don't see it in any other condition. And so that family had neurofibromatosis within the family, and the child presenting with the tumour was the first presentation in that family. Again, we really commonly see squints. I see millions of squints every clinic, but when I was working in Leeds about 15 years ago, or maybe longer, this 5-year-old boy turned up, and he'd had a bit of a squint on and off for a few weeks. He'd been a bit unwell for a couple of weeks, and Mum noticed that over the past couple of weeks he started to turn his head and look out the corner of his eyes. When he came to clinic, Mum said he's very unwell, he's got this bug that's going around, he's vomiting a lot, gastroenteritis, and she asked the registrar if he could be examined some other time rather than dilating the pupil, so he said, yeah, that's okay. But unfortunately, the child came back that night, and he was very, very, very unwell. And you'll see here what on the previous slide, he's got a head position because he's trying to maintain binocular vision. So kids don't complain of double vision. They just put their head in a position where they can get single vision. And the reason for that was that he if you look at his eye positions here, you can see he's got a convergent squint. If he looks to the left, he can get his left eye right over into the corner of the eye. But if he looks to the right, he can't quite abduct his right eye. So he's got a lateral rectus palsy, a sixth nerve palsy. So the suspicion is he may have raised intracranial pressure. How do you diagnose that? Well, you have a look at the back of the eyes. And this child had massive papilledema. And so this child has certainly got a posterior fossa tumour. I always say to the medical students and the trainees, they said, what would you do? And they say, I'll do an MRI scan. I said, how would you do an MRI scan? I said, well, get the radiologist appointment. They said, how do you go about organising an MRI scan? And my point is that this is a very acute event. that child, if you go onto ICE and type in this instructions, a child might get an MRI scan in the next few days or week or two, but this child could die that night, and you really need to go to the radiologist, cap in hand, with the request in hand, and get that child right along to MRI unit. And this child had massive hydrocephalus. He had a small glioma in the third ventricle, which was obstructing the aqueduct. He was shunted that night and had an excision biopsy of the tumour and did quite well after that. So, see lots of squints every year. Once every 15 or 20 years, it's a tumour. Nystagmus, we always know that nystagmus is not good. I would say that most of the time in the clinic, we see congenital nystagmus, and that's often an abnormality of development of the visual pathways, motor visual pathways, or more commonly albinism. And children with congenital nystagmus, actually, although it's congenital, do not have nystagmus at birth. They tend to develop around 2 or 3 months after birth, when the visual pathways, when the vision is just developing. So congenital nystagmus, conversely, often presents after around 2 or 3 months. And it's usually symmetrical, so it's in both eyes, it's usually horizontal. So anything that's out with this really breaks the rules and needs further investigation. This is a child who came to my clinic. He was 4 months old, and Mum had noticed he had a bit of a wobble in his eyes when he was 2 months. You can see here he's got a slow nystagmus, which is equal in the prime position, and when he's looking to the side, it's slightly jerky, so it's horizontal and it's symmetrical. And as I mentioned earlier, we want to look at congenital motor nystagmus and albinism. And if we put them on the slit lamp, you can see here the red reflex is shining through the pupil, but you can see the red reflex coming through the iris here. You can see the outline of the lens. And this is iris transillumination. We've all got, even with blue irides, got a pigmented layer which stops the red reflex coming through the iris. And this child this is very typical of albinism. So we don't really need to do any more investigations on that child, apart from perhaps asking Dr. Gowdy to see the family to elucidate the genetics. This child, you'll see, is a different presentation. She's 11 months old, and Mum had noticed nystagmus about the past month. Mum worked in the clinic in Perth, so I knew her quite well. And the child came along, and you'll see here, you can just see they've got a wobble. She's got a nystagmus just in the left eye, not in the right, just the left eye. Do you see that? So she's presented slightly out with our rules, and it's only present in one eye. And what I should mention is that I was slightly concerned, and you're trying to scrabble for a bit of history to go on. When I saw the child, she looked very abnormal. She looked like a little marionette doll. She had a very large head, or probably a normal head, but very, very cachectic, wasted body, very tiny little limbs. And when I flicked back through the notes, she'd seen the paediatricians with failure to thrive. She wasn't growing very well. She had initially grown reasonably well, but then her weight remained stable, all the head size was increasing. So there's obviously something a little bit unusual going on, but nothing very specific for paediatricians. But I think with the eye findings, that would make a visual pathway problem high on the cards, and we got a scan, and she had a huge hypothalamic glioma. She had what's called a diencephalic syndrome, so she had some of her pituitary hormones were affected, and she's failing to thrive, and she had a visual pathway tumour. And I think really, the paediatricians see lots of kids with failure to thrive, but once this child presented with a new onset nystagmus, that was something that rang alarm bells. Just want to discuss a few cases now with disease around the eye rather than sort of neurological. Every year we see paediatricians admit loads and loads of cases of orbital cellulitis or preseptal cellulitis. And very common. Sometimes it's bilateral. These often used to be hemophilus before we had the vaccine. So this little girl's got a very puffy, inflamed right eye, slightly closed left eye. This boy's got a huge degree of eyelid closure, proptosis. And these kids, it's a cellulitis, so there's cellulitic infiltration around the eye. These children have usually got a temperature. They've got a raised white count or a raised CRP, and they're often quite unwell. They've often had a cough or a cold. Sometimes when it gets bad, the eyelid swelling can be rapid. We've sometimes seen kids in the morning who've presented with mild eyelid swelling, and then by late afternoon they've got proptosis and a closed eyelid. Their eyelid motility might be restricted, and sometimes have optic nerve compromise. And some of these kids are seriously unwell. They have brain abscess, and they become quite unwell. So it can be a very rapidly evolving serious condition. Sometimes if it's getting worse or not getting better, or significant proptosis, we might need to do an MRI scan, and that's not easy in children, but we might be looking for a subperiosteal abscess. This child the sinuses are stuffed with opacity and inflammation, and there's a little subperiosteal abscess, and this usually needs draining by the ENT surgeons. So it's a pretty common problem we see. But we need to also recognise when it's not orbital cellulitis, and there's some little rules that I often have, which sometimes I break, but I think if the history is for longer than 2 or 3 days, that's of concern. And we just had a child recently who had an unusual tumour where the history was for 2 weeks. Mum and Dad had a photograph of him playing football with this bulgy eye. He's well enough to play football, yet he'd ignored his eye, and so that rings alarm bells. I think if there's an absence of sepsis, so if a child's white count is normal, the CRP is normal, the apyrexial, then we've got to think about whether there are other possibilities. And I remember one of the paediatric neurologists in Leeds always said to me one time, he said, if you see an unwell child with absent acute phase markers, you must always suspect an underlying cancer. And so orbital cellulitis these other conditions can sometimes masquerade as orbital cellulitis. We see rhabdomyosarcoma, which is a malignant tumour of the muscle around the eye. Sometimes hemangiomas, lymphangiomas, neuroblastoma, seen a meningioma present in this way. This is a child who we saw a few years ago, probably Margaret, and knows quite well. He's probably an adult now, but he'd presented with a month's history of quite bad leg pain, and he'd had increasing difficulty in walking. He'd lost some weight, he wasn't eating, he'd had a bit of a history of nosebleeds, and he'd got a cellulitis of his upper lid, cellulitis in inverted commas. And at that stage, everything was a bit non-specific. There was consideration whether he got an inflammatory arthritis, juvenile chronic arthritis, or whether he got an affective disorder. You'll see that his blood tests were fairly unremarkable, really, slightly raised CRP. And this is a picture of his eyes. He got quite good vision, but he had a little bit of ptosis. His eyelid is drooping a little bit. And the eyelid, it's not apparent very well on the photographs, but his eyelid was slightly protruding. It was slightly proptotic. And when he tried to get him to lift his left eye, he couldn't elevate his left eye very well. And so that's a little bit of concern. But you'll see it's not really cellulitic. It's a little bit pinkish, but there's not obvious infection or inflammation around the eye. He had an LP that showed some atypical lymphocytes, and he had an MRI scan. And you'll see here on the MRI scan he had an intraorbital tumour, solid tumour, which is compressing the left eye and pushing it downwards a little bit. But the sharp-eyed amongst you will also see that he's got some tumour within his sinuses as well. And biopsying orbital tumours is very difficult if it's behind the eye. It's fraught with difficult tiger territory, can cause massive hemorrhage, loss of vision. But the ENT surgeons are pretty good at looking at the sinuses, particularly Paul White and Pete Ross. And they were only too pleased to have a look at the sinuses, and they did a biopsy through the sinuses, and it turned out to be a Burkitt's lymphoma, B-cell lymphoma. He did very well following chemotherapy. So it's a child presenting with fairly vague symptoms of joint ache, in whom the ophthalmic signs helped clinch the diagnosis. This is another case who'd presented with a 2-week history. He'd had, again, painful legs, particularly the feet and knees. He was unable to walk, and his eyes had become quite swollen and red. Prior to that, he'd had a bit of a fever. He was apyrexial. He didn't like his joint being examined or moved around. And at that time, there were working diagnoses whether he had an arthritic condition or Still's disease. He had a raised CRP, mild lymphocytosis. But I noticed he was an oromorph for the pain. And this child came to see me. I was in a paediatric eye clinic. There was a lot of patients waiting. He came through the treatment room, which is where our trainees see a lot of the eye casualties. And he was presented me as Querey-Reiter syndrome, which is usually a uveitis or a conjunctivitis associated with a seronegative arthritis. And he'd seen somebody the day before in the eye clinic and been given chloramphenicol for possible conjunctivitis. Now, you've probably all had kids who've had conjunctivitis, or maybe you've had it yourself, but your eyes are pretty red and they're pretty sticky. The eyelids and lashes are pretty sticky. And this child has got some diffuse swelling around his eyelids. And when you look at his eyes, he's not got lots of inflamed blood vessels around the limbus. So you can see there's a white zone around the corneal limbus. What he's got is some sort of pinkish tissue underneath the conjunctiva in both eyes. So I was seeing this kid in a busy clinic. I was a little bit stumped. I knew this was some sort of infiltrative process. We sometimes see things like lymphomas and things. I needed some time to think about things. He went back to the ward, and I was thinking about whether we should be doing a biopsy or a scan. And when I went back down to the ward, I opened his nose, and the first thing I saw was the fact that his blood count, although his white count was 10, he had a leukoerythroblastic film appearance, and this was on the 28th. So I was a little bit worried about it when I rang Rosalie Wilkie, who came hot foot round from her office, and she got the blood test repeated that day, or that minute virtually, and you'll see his white count has gone up to 34, and his LDH was way up, which is apparently very typical. I think Rosalie built acute myeloid leukemia. So this child was blue lighted down to Edinburgh to start chemotherapy for acute myeloid leukemia, and so we didn't need to do any biopsies. But his presentation to the eye department had focused on something that was clearly abnormal, and stood out from his other fairly vague symptoms of, just general malaise and joint ache. So, kind of just to summarise, really, I presented this at an emergency ophthalmology meeting, perhaps about paediatric emergencies, and one of the things I said was actually dealing with kids with cancer is a relative emergency. I think often they've got cancer develop very rapidly, and as Margaret said, need treating fairly urgently. And I think that as I mentioned earlier, the ocular signs can clinch the diagnosis, so they're an important part of the examination. I think it's very important to know who to contact and how to relay your concerns. I think one of the things we're not so good at in the eye clinic, patients come to the eye clinic, they're often in the treatment room with lots of patients with conjunctivitis or aching eyes, and we write in the eye notes and we write lots of jargon, and so I try and tell my trainees, you must write in the paediatric notes, you must write in capitals in language it's very simple to understand, like infiltrative process, query lymphoma, and these sort of things, and then makes the other doctors from the other disciplines looking at those notes, puts them in the picture, and it makes things click much quicker. So, thank you for listening to me.
Right, that's fantastic. I think the most interesting grand rounds are ones where I know basically nothing about the subject, and it's. I think I mentioned a few weeks ago we've had a few way below the diaphragm, and this is way above the diaphragm. So that's absolutely fascinating. I find that this stuff really very interesting. Has anyone got any questions or comments they'd like to make? Refuting or confirming Nick's ability on the bike? Yeah. No. There was a very high-profile case recently of an optician who missed someone's papilledema.
Yes.
And the case hung on the fact that they'd not only missed it by the ophthalmoscope, but missed it on a photograph as well. Yes. And some of us general physicians are a little bit spooked about,
yes.
We don't look at eyes very often. I think there's already diabetologists in the room probably do look in the eyes more often than we do, but when we're on tape, look in some eyes, if we miss papilledema, we're going to be strung up. Has times changed? Should they all get photos? Should people who get headaches and are worried about it come to you guys, get photos done?
I think that case has spooked everyone, and it's like all these things. You'd like to know a bit more about it because she's had a manslaughter charge against her, hasn't she? I've subsequently found out that the opticians take a lot of photographs. The photographs have been taken of the child and not looked at. So I think that was the main problem. But since then, we've had massive numbers of kids referred with query, swollen disc, and it's a huge kind of logistical problem in the clinic. And we've got lots of fancy equipment in the eye clinic now. We have scanning laser ophthalmoscopes and all that sort of thing, and nothing is any good at discerning papilledema from a good history and a good examination. I think, as I mentioned earlier, that one of the history is very important. You get a patient who comes and they've got new headaches in the morning, they're vomiting, or they're worse when they're bending or lifting. I saw a 20-odd-year-old female the other day who had a sudden onset headache just after she delivered a child, and she'd had a dural sinus thrombosis. So these are events, significant events. They're not kind of had a vague headache a few weeks ago. So I think the history is very important. I think examination can be a bit difficult. Sometimes these kids get over-investigated. But I think I try and discharge a lot of kids just on the examination. We can do ultrasounds. One of the most common things is that we see little drusen, which are little hyaline bodies, which we sometimes see within the optic nerve, and they can make the nerve look quite swollen. They're much more obvious in adults, so they sort of come to the surface of the nerve during the second or third decades, and they're pretty obvious then. But in children, they can just look like swollen discs. But in these kids, there's no signs of disc hemorrhage, there's no signs of Cottonmore spots, papillary dilation, no spontaneous venous pulsation. So there are other signs you can look at, but I think a good history is pretty good starting point.
Okay, anybody got any questions or comments? Then I shall remind Nick that although he has to go to an operating list every week, he can watch Grand Rounds on the Dundee Grand Rounds archive. The IT people have now up to date with all the videos, so if you've missed any Grand Rounds, you can go back and watch them, and don't worry, they cut out me from the beginning. They never do that, and they cut out me at the end, so you don't have to listen to me drivel on. But they are there available all the way back to 2013. It counts as CPD, and you can stick it in your appraisals. I'd like to thank Margaret, who's gone, and Nick for giving a very interesting presentation. Next week, the haematologists return for their third crack at massive hemorrhage policy. Thank you very much for your attendance, and see you next week.